All right, it's just time. So, a very good morning, good afternoon, again, good evening to all of you who have joined this meeting today. Myself, Sanjog Chavan, working in Edwards Life Sciences Critical Care, a professional education for JPAC. Really welcome you all on behalf of Edwards Life Sciences for this really insightful and really look forward meeting today. I'm really delighted to have Dr. Ashish Khanna with us, who I'll be quickly introducing you to you all very shortly. So, to quickly give you an overview of the meeting today, the meeting title is Intraoperative Hypotension, Understanding the Value of Monitoring, Prediction, and Prevention. The meeting will go on for the next 1 hour. At the end, we will also have, definitely time for everyone to ask questions and answers. A quick overview. I'll be introducing Dr. Khanna to all of you. I believe most of you already know Dr. Khanna. He's really very well known in this area of expertise on intraoperative hypertension and many more topics. Dr. Khanna will give his talk for about approximately 35 to 40 minutes. And in the end, approximately 10 to 15 minutes is what we will have for a Q&A session with all of you. Quick note for all the attendees who have joined this meeting today. If you have any questions, any comments, anything that you would like to ask Dr. Khanna, please feel free to type it in the chat box that you would see on the right side of your screen. And please type in your questions, and we'll try to answer as much of them as possible when we move towards the Q&A session. With that, I will quickly introduce Dr. Khanna. I think Dr. Khanna's CV is really, really awesome, and there are so many things we could put in, but I really selected a very few that I have on this slide. Dr. Ashish Khanna, he is currently the associate professor and vice chair for research anesthesiology at Department of Anesthesiology, which is a section of critical care medicine at Wake Forest University School of Medicine, that's based in Winston-Salem in North Carolina. Dr. Khanna is a member of the Wake Center for Biomedical Informatics, the Center for Healthcare Innovation, and the Wake Forest Hypertension and Vascular Research Cardiovascular Science Center. He is also the director for Perioperative Outcomes and Informatics Collaborative, which is a large perioperative outcomes collaborative program and is a center of excellence for clinical trials across specialties. Currently, Dr. Khanna is also the vice chair for ASA, which obviously everyone knows, and committee on the critical care medicine and chair for the abstract review committee on critical care medicine. He's heavily engaged with the Society of Critical Care Medicine and currently chairs the research section. He's also on the steering committee for anesthesiology section and the Discovery Research Network Oversight Committee, along with being a program co-chair for the 2023 Congress. He's on the board of directors on the SOCA, which is the Society of Critical Care Anesthesiologists, and has more than 120 peer-reviewed papers, 24 book chapters, editorials. Is invited, in a lot of national and international conferences to talk about his work and prestigious national and international forums. His research interests lie in prediction of post-operative respiratory and cardiac events on the regular nursing floor, using use of large data sets for perioperative outcomes research, effects on hypertension in critically ill patients, and the use of novel vasopressors in shock states in the ICU. So with that, you can really see Dr. Khanna is extremely busy, and thank you so much, Dr. Khanna, for taking out your valuable time today. And you're so engaged in so many different associations and so many great projects going on around. So with that, I would like to hand over the floor to Dr. Khanna and start the whole session. And Dr.
Thank
Khanna,
you.
Yeah, I'll go ahead and share this. Share the slides.
Thank you, Sanjog. And can everyone hear me okay?
Yes, we can get it. Fine.
Okay, perfect. Well, thanks, Sanjog, and a big hello and good morning and early good afternoon to friends in South Asia. It is about 10:30 at night here where I am, and I'll try my best not to let any sort of sleep affect me today. I have loaded myself with some coffee, and we should be good. I appreciate the very generous introduction, Sanjog. I'll try today to talk my way through intraoperative hypotension and really help you all understand the scope of the problem and how accurate documentation, collection of intraoperative hypotension data, appropriate monitoring, and along with prediction and prevention can help improve patient outcomes. And my hope is that by the time I come to the end of this, you all will have a better overall understanding of the subject area, and then you could take that back to your clinical practice environments and try and improve the quality of patient care. And like Sanjog said, I'm open for questions afterwards and hope to have a good discussion at the end. Next slide, please. So Sanjog already gave an introduction. This is where I come from. It's a 900-bedded university hospital system called the Wake Forest Health Network. It's in Winston-Salem, North Carolina, which is the southeastern part of the United States, and the nearest big city is Charlotte for those who've been to this part of the world, but it's a fairly pretty part of the country. Lots of greenery and beaches close by, and so are the mountains. So any day, some of you want to come visit, we'll be happy to be host to all of you as well. Next slide, please. So like I said, I'm going to talk to you all about the blood pressure journey, really taking your patient in the operating room and sort of seeing how the evolution of intraoperative hypotension happens, where is the evidence, and what we can do to improve outcomes. Next slide. So this is interesting. This is actually a textbook of mine from several years ago, and it was actually handed down to me by one of my early professors in anesthesia. The reason I bring this up is there was actually a time where there used to be chapters like this in anesthesia textbooks that were labeled induced hypotension. If you look at some of the headings, it actually says safe hypotension and techniques of induced hypotension. And in this virtual audience, I cannot see all of you, and I don't know your age group and demographics, but I often say if I was really in an area where I could see you all, I would ask you, like, how many of you have practiced induced hypotension intraoperatively in your careers? And I'm sure there's a few of you, especially those who've been trained in the 90s, who have indeed practiced induced hypotension. Next slide. So is controlled hypotension actually safe, is our question, right? So if you look at textbooks that were published 30, 40 years ago, there were chapters on safe intraoperative hypotension, and the authors actually made some good points that I've tried to highlight here, is that when hypotension comes on slowly and is not necessarily hemorrhagic hypotension, that both the myocardium and the cerebral vasculature has autoregulatory mechanisms to at least some level where flow can be preserved. Now, there was a time where we would all feel that if we drop our patient's blood pressure intraoperatively and we do it in a slow, controlled manner, that surgical fields are better, surgeons have less bleeding, and therefore we need less blood transfusion, et cetera, and we improve patient outcomes. This has drastically changed now. We never see chapters like these in textbooks today. And there is a reason for that. And my slides to follow will actually start showing you some of these reasons. Next slide. So as I talk about the risks of hypotension, understand that hypotension is not just a number. It's not just a map of 60 or 65. You have to quantify it in terms of duration of time. So it's always an area under the curve. So this amount of hypotension for this amount of time will be different than another amount of hypotension for another amount of time. So always quantify it as an area under the curve. Next slide. This is, as I start talking about the evidence around hypotension, this is one of the most important landmark papers on intraoperative hypotension. First author Walsh and senior author Dan Sessler, who's actually one of my early mentors in outcomes research. And this paper that came out about 10 years ago in anesthesiology really established the thresholds of intraoperative hypotension. We all knew hypotension was bad, but we didn't really understand thresholds. So on the x-axis here, on the left side, is the lowest mean arterial pressure and the probability of acute kidney injury on the y-axis. And on the right side of your screen is again lowest mean arterial pressure and probability of myocardial injury. And at a map of around 65, that is about the inflection point where you see the probability of acute kidney injury and myocardial injury. Myocardial injury probably at a map about 60 onwards start going up. Next slide. So a map of 65, based on what I just showed you, appeared to be that threshold of myocardial injury and acute kidney injury in the intraoperative period. The other question people ask often is, well, what about baseline pressure? What if my patient is chronically hypertensive, comes to the operating room? Where do I keep my patient's intraoperative blood pressure? So again, colleagues Dan Sessler and Salmasi did this very neat work where they retrospectively examined data and they looked at a comparison of a baseline map versus an absolute change in thresholds. And they concluded that a 25% reduction from baseline worsens the probability of myocardial injury, but it is no different or no better than using an absolute threshold of a map less than 65. So if you look at your slide here, on the left side is a lowest absolute map on the x-axis. On the right side is a percent decrease below baseline. And if you look at your y-axis, they are the estimated probability of myocardial injury. And if you look at the cumulative 1, 3, 5, and 10 minutes that have been plotted here, the probability ranges are about the same. So if you don't know your patient's baseline map, and if you don't really believe that it's accurate, then you can just follow an absolute map less than 65. That was the guidance that came out of this work. Next slide. And they essentially replicated the same thing in the cohort of patients with acute kidney injury within the same broad work, where again, if you don't know or don't believe your baseline map, then you can still go by an absolute map less than 65. Next slide. So I've talked about intraoperative hypotension and acute kidney injury, which could be a transient rise in serum creatinine postoperatively. But what about acute kidney disease? Now we've tried to now define an entity called AKD, or acute kidney disease. And this work that we just published in the British Journal of Anesthesia looks at two categories of creatinine increase. So suppose a patient has a creatinine increase in the first week postoperatively and then continues to have that creatinine increase from day 7 to up to 3 months out. That patient is classified to have persistent acute kidney disease. The other phenotype is a patient who doesn't have for the first week or so any increases in creatinine, but then does have a delayed presentation, which is more than a week out to 3 months out of a creatinine increase that satisfies the KDIGO criteria. That patient is the delayed acute kidney disease variant. Does intraoperative hypotension make a difference, or is it associated with either persistent or delayed acute kidney disease was our question. And what we saw in a fairly large retrospective analysis was that persistent acute kidney disease, which was this persistent increase in creatinine that lasted all the way out to this big window of up to 3 months after the intraoperative period, was associated with intraoperative hypotension of MAPS less than time-weighted average MAPS less than a MAP of 55. 55. Whereas the delayed variant was not really, did not meet any criteria of association whatsoever. Really meaning to say that intraoperative hypotension may be associated not just with a transient increase in creatinine, but a persistent increase in creatinine that could come up to a week out and up to a month after surgery. The delayed presentation of acute kidney disease might be still relevant, but doesn't seem to be associated with intraoperative hypotension. Next slide. So the other question people ask is it only math? And, the short answer is yes, it is math that appears to be a really important driver of outcomes, but systolic blood pressure, diastolic blood pressure, and pulse pressure are also important. And this work that we published in Anesthesiology in 2020 looked at the 4 different blood pressure components and looked at the overall predicted probability of organ system injury and compared the patterns. And essentially what we saw was that a MAP less than 65, SBP less than 90, diastolic pressure less than 45, and a pulse pressure less than 35, or a pulse pressure less than 35, all appear to have about similar increases in predicted probability of myocardial injury. If anything, the diastolic pressure did not appear to have as steep of an increase in predicted probability, but these were the thresholds. These were the change points we saw, those important inflection points. So important numbers to keep in mind, although, again, that map of 65 comes back quite a lot in the intraoperative period as that sort of common number that all of us should know. Next slide. Okay, timing of hypotension is really important. All of us practice anesthesia, push out anesthetic agents, induction agents. We typically see a drop in blood pressure soon after intubation and before the surgeon picks a knife and cuts across the abdomen. This period of hypotension from induction to incision constitutes up to 1/3 of all intraoperative hypotension. And this peri-induction hypotension is equally associated with acute kidney injury compared to any other hypotension that happens in the intraoperative period. So we, as anesthesiologists, are very much in charge of this hypotension that happens around the period of induction and in post-intubation. And we need to take accountability and say that, yes, we can actually reduce this hypotension and maybe make a difference in outcomes. Next slide. I'm going to talk about some larger data sets very quickly, just to emphasize the fact that more and more work is being done and has been done over the years. This is, again, our recent work. This time looked at nearly 400,000 surgical patients of all sorts across the United States. And what we saw was, next slide. Number one, the general feeling that, as you get older, the risk of hypotension is more. We are not see that an age of 18 to 40 versus an age greater than 80 in any way or shape was more immune to hypotension versus another age. Yes, there was a difference in the amount of risk, but younger people, when they were exposed to hypotension, were also likely to have adverse myocardial and cerebrovascular events. Bottom line being that no age seemed totally immune. If you go down this graphic that's in front of your eyes right now, all of our adjusted odds ratios are in the range of anywhere from 1.3 to 1.1, and all of them being statistically significant, right? So no age, at least in this associated relationship, is totally immune from the effects of intraoperative hypotension. Next slide. And we also attempted to describe intraoperative hypotension in various different manners. And I'll talk about this in the slide to follow. But in this slide, you can see that whether we used absolute maximal decrease, that is AMD, or a time-weighted average MAP, or an area under the curve, or an absolute cumulative time, no matter how you define or describe intraoperative hypotension, all of it is associated and relatively strongly associated with postoperative outcomes. Here our outcome was major adverse cerebrovascular and cardiovascular events. Next slide. So intraoperative hypotension measurements are really important, and I want to spend a little bit of time on this slide. There's four basic ways how you can define intraoperative hypotension. If you look at, this is a mean arterial pressure graph, and there is time on the x-axis. Either you can just add total duration of hypotensive episodes in minutes. So you add this A plus B plus C plus D. Patient has 10 minutes of hypotension here, 5 minutes here, 15 minutes there. Keep adding that up. You have cumulative hypotension minutes over a surgical period of say 3 hours. Okay. The other way to do it is absolute maximal decrease, which is the lowest absolute value. So here, the lowest dip or trough is this A here, where the map goes down to 40, right? That's absolute maximal decrease. Total area under threshold is just the sum of all these orange colored areas. And in my opinion, the most important way to describe hypotension is this time-weighted map or time-weighted average map, which is the total area under threshold, which is this area plus this area, this area, this area, A, B, C, D, divided by the total intraoperative OR time, which is really important because, the longer duration of surgery you have, the more chances that your patient will have these dips in hypotension. So you have to account for the exposure to surgical time or anesthetic time, and this provides you an appropriate denominator to average things out. Next slide. Intraoperative hypotension, ladies and gentlemen, is also expensive. This is a most recent analysis where we looked at, again, a large EMR data set, and we found that intraoperative hypotension was associated with the risk of being discharged to a care facility afterwards, with 30-day readmission, with postoperative extended length of stay, with length of stay in the follow-up period, and then with repeated ED admissions after discharge from the hospital. So what you do in the intraoperative period is now making a difference with organ system failure, and is also making this difference in healthcare economics. Next slide. Documentation is very critical, and what I'm going to show you here is just a little snapshot of how we document intraoperative hypotension. So we have documentation in our hospital EMRs, where continuously all bedside monitor data or monitoring data from the intraoperative monitors is going into the EMR. And we have documentation within the EMR itself. But what if I want to look at how my hospital is performing compared to all other hospitals in a system? So we report to something called the Multi-Center Perioperative Outcomes Group, or MPOG. It's based out of Michigan. And all of the centers that report to MPOG then get a dashboard like this. And here, for example, I've tried to highlight, I'm sorry, it's in very fine print, low MAP, that is less than 65. That's in about 93% of our cases were good with a low MAP threshold. And then here, low MAP less than 55, where 100% of cases were in the green. That is, we did not go below that threshold. The threshold here was at least 90% of your cases should avoid low MAP less than 55. And again, if you look across this dashboard, there are other criteria as well, high glucose, hypothermia, antibiotic timing, et cetera, et cetera. So this is how our dashboards look like. Next slide. And again, if I go into further details, I can actually open up the low MAP less than 65, and in the upper left-hand corner, you look at our overall score. That's 93% compared to a benchmark threshold of 90%. If you go over to the right side, this red line here is the benchmark. The blue line is how our institution is performing, and the gray line is all institutions across the country. And then it also gives you analytics. That's the left side of your screen in this box here. Minutes below 65, minutes below 65 that are okay and that are flagged. Patient age, whether a patient got a labor epidural, cardiac procedure, ASA class. So it actually breaks it down and so on and so forth. Next slide. Similarly, this is low MAP less than 55, and here 100% of our cases are okay, which means that literally no case went to a low MAP less than 55 at all. which is obviously good news. Next slide. And again, this is avoiding monitoring gaps, which I feel is really important. I'll tell you about monitoring in the slides to follow. But if we don't monitor properly, or we don't monitor based on standard ASA monitoring criteria, then obviously we miss a lot of hypotension. So here again, we've achieved at least 95% of our cases getting a good score in terms of avoiding blood pressure monitoring gaps. Next slide. Very quickly, I wanted to show you this reference. This is a very comprehensive review that Dan Sessler and I wrote and published it about 4 years ago, and it really covers a lot of what I've said in the preceding slides, a lot of heavy data that I presented to you. And if anytime all of you want to read it, I do highly recommend this. It's a very good piece, and we put a lot of effort into this. Next slide. So I gave you lots of data. Lots of retrospective data, lots of associations of map, less than this, having a odds of association and an odds of association with acute kidney injury, myocardial injury, major adverse cerebrovascular events, etc., etc. On your slide here, you see about 8 or 10 different large retrospective data sets that have looked at the association of map of blood pressure components in the intraoperative period and the postoperative period in the ICU. All of them are really important references. But do understand that these are associations, which doesn't necessarily mean causality. A big problem with large data sets where we do retrospective analysis is that there is always hidden confounding, which means that we're not sure that hypotension is leading to these problems, or whether the problems themselves are leading to more hypotension. So it's a little bit of a problem where someone could have myocardial injury, which could cause hypotension, and fallaciously give us a feeling that folks with hypotension have more myocardial injury. So that's why we need to do randomized interventional trials of blood pressure, where we prospectively allocate patients into blood pressure groups. Next slide. So can we do randomized blood pressure trials? The answer is it's very difficult to do blood pressure trials in the perioperative period. Ethically, it's very difficult to allow your patients to be purposefully hypotensive. We do know that there is harm associated with hypotension. Plus, it's very difficult to keep patients at very specific blood pressure targets throughout their intraoperative or even postoperative period. But there's been some randomized trials that have been attempted, especially more recently. This is the INTRUST trial. Emmanuel Fouchier in Paris who led this trial, published in the JAMA in 2017. Their two comparator groups was a standard treatment, which meant when a patient's blood pressure dropped to a systolic less than 80 was when they intervened with an intraoperative vasopressor to correct it, versus individualized treatment that meant that they kept blood pressure within 10% of baseline at all times intraoperatively. On the slide here, you can see the probability of postoperative organ dysfunction, and folks who got standard treatment, where systolic fell to less than 80, were the ones who had a significantly higher risk of probability of postoperative organ dysfunction. A very statistically significant difference here, a hazard of 0.66 that was separating these two outcomes. So clearly a strong signal, even though it was a small RCT, only about 300 patients. Next slide. However, there's other randomized trials as well. This is a single center randomized trial that was just published in the Journal of American College of Cardiology, where the comparators are a target map of more than 60 and a comparator there being a target map of more than 75. So two arms, keep map just above 60 or more, and the other one is keep map just above 75 or more. On here, you can see the composite primary outcome that crosses the midline, so not statistically significant. Acute myocardial injury, not statistically significant. And 30-day MACE and AKI, not statistically significant again. What does this really mean? This means that we actually need to do more randomized trials, have appropriate power calculations and large sample sizes, and maybe find the right blood pressure target numbers to compare. In my opinion, these two targets were too close. Any MAP more than 60 would be difficult to keep in that range, and similarly, more than 75, there is not enough separation. This is almost like comparing two normal blood pressures, whereas truly not comparing hypotension versus a higher blood pressure. So we're probably still searching for that best randomized controlled clinical trial. Next slide. Guardian is an ongoing, very important perioperative blood pressure management trial. In fact, it is going to be the largest trial of perioperative blood pressure management, where we are intervening and separating patients into two intervention arms. One arm keeps the MAP more than 85 intraoperatively, and also keeps systolic more than 110 in the postoperative recovery period, both in the PACU and on the general care floor. The other arm keeps MAP less than 65. So in the other arm, we only intervene once the MAP drops to below 65. The outcome is a composite of perfusion-related complications in the 30 days after major non-cardiac surgery. Planned enrollment 6,000 in about 50 sites all over the country. And Dan Sessler is leading this work up at Cleveland Clinic, but we are a very important site. We're already doing these patients. And you all should stay tuned, because I truly feel that this trial will set the stage and answer a lot of questions that are as yet unanswered. Next slide, please. Very quickly, I'm going to talk about baseline blood pressure. So all of these blood pressure arguments, your patient comes to the operating room with a MAP of 100 or 110 or 120. Next slide. We really don't know why baseline blood pressure is important to us and what a true baseline is. The problem is, next slide, that if we looked at what a true baseline blood pressure is, we don't know whether it's in the preoperative induction area, whether it's in the preoperative holding room, whether it is in the patient's office visit 2 days before surgery, or whether it is the patient's last visit to a doctor that was 2 weeks before surgery. Bernd Sagel has here shown, next slide, that when he put his patients on ambulatory continuous blood pressure monitoring, he found that daytime and nighttime and first blood pressures were all very different from immediate pre-induction blood pressures, meaning thereby that it's very difficult to know what a true baseline blood pressure is. And meaning thereby that in the ideal case scenario, all of your patients should be wearing some kind of a device that they take home for a week or so before surgery, and that device continuously records their blood pressure, and then they come back and give you that data, and then you know what your patient's sweet spot is in terms of a physiological baseline. We are not quite there yet. All over the world, it's very difficult to do these kinds of practices. But this is probably where precision medicine and the next level of blood pressure management is going to. Right now, yes, we know baseline pressures are important, but we don't really know what an accurate baseline blood pressure is. Next slide. The other component is MAP versus perfusion pressure. So here you see a little balance between cardiac output vascular resistance and mean arterial pressure on one side and outflow pressure on the other side. And that balance determines perfusion pressure. Next slide. So we don't really measure perfusion pressure because we don't measure the balancing pressure all the time. The balancing pressure, for one example, can be intra-abdominal pressure. We have just recently finished this work where we continuously measured intra-abdominal pressure in post-operative cardiac surgery patients in our CVICU. And amazingly, we saw, if you can click to the next one, and the next one, and one more, please, that intra-abdominal hypertension was really, really common. You look at all of these graphs going across your screen, even say, for example, an intra-abdominal pressure more than 20 was present in about a fifth of our patients for a continuous of 10 hours in the post-operative period. You look at the formula I put up on the screen here, abdominal perfusion pressure is the difference between mean arterial pressure and intra-abdominal pressure. So just knowing a map may not be sufficient if you don't know your outflow pressure. Here it is intra-abdominal pressure, because the real perfusion that the organs are seeing is the difference between MAP and IAP. As of now, we don't measure IAP continuously one way or the other. And the surrogate for IAP sometimes is CBP. We don't measure that either continuously, right? So what I'm trying to tell you is that look beyond MAP. The world is going to a more precision medicine-based outcome, which is perfusion pressure. Next slide. The other thing is frequency of blood pressure. It's really, really important. We all want to put arterial lines in all of our patients if we could, but we know that's not possible. I think it's probably dangerous. Non-invasive intermittent is the gold standard. The ASA sets certain recommendations of continuous blood pressure monitoring intraoperatively with the non-invasive blood pressure cuff. Could we do non-invasive continuous like an A-line? Yes, that is probably the goal, and the early data seems good. Next slide. And very quickly, yes, this is a common sense study that we did, where we saw that if you put arterial lines in all of your patients, or you randomize patients to arterial line based monitoring versus non-invasive blood pressure based monitoring, there is at least twice as much hypotension that is detected at each of these thresholds, 70, 65, and 60, with arterial catheters. Next slide. Kamal Maheshwari did this work where he used the ClearSight monitor, where he did see that the ClearSight, which is a non-invasive continuous blood pressure monitoring system, that it was able to detect more hypotension. And not only was more hypotension detected with ClearSight, when the providers were provided that information, they corrected more hypotension as well. So more monitoring in the intraoperative period generally means more correction of hypotension, which probably means better outcomes. Next slide. Importantly, do not ever forget microcirculation. I've talked a lot about MAP, blood pressure. This is macrocirculation, large arteries, big blood pressure, cardiac output, SVR. The real problem is there is a lack of coherence between micro and macro circulation, especially when you have septic patients and inflamed patients. And, there's a lot of published work around in this area. Next slide. This is, for example, if you can press the next slide button. Healthy patient on the left side and a late septic shock patient on the right side. And these are video clips. If Sanjog, you could, if they could play, please. Oh, can you go back a slide? So this one, you can see on this side, the healthy, this is a under the tongue camera that is looking at microcirculation, healthy patient, lots and lots of capillaries. And if I could play this, you would see good blood flow. Late septic shock patient, you look at the microcapillary density, it is much less compared to the healthy patient, and the blood flow itself is very sluggish. These two patients are at the same blood pressure, but the late septic shock patient is on 2 vasopressors to maintain that blood pressure, clearly showing that in addition to pressure, flow in the microcirculatory beds is really, really important. Next slide. And these slides to follow really make this point. This is intestinal villus microcirculatory flow. This is baseline, healthy patient. Everything seems to be flowing along really, really nicely. Next slide. Again, left side is that baseline. Everything flows really nicely. Right side is that the same patient who has now bled about 2 liters and has 3 vasopressors, you see the difference here. Same blood pressure maintained, but the right side clip, you can see how sluggish the blood flow is in those tiny microcapillary beds, how blanched and swollen they appear compared to the left side. This is the difference, right? Not just pressure, but maintenance of flow is really important. Next slide. And that's why I say measure your cardiac output. If it won't give you microcirculation, it will at least allow you an idea of flow. This is an example of the way things should be, right? Top panel is MAP, middle panel is cardiac output, bottom panel is SPR. You have a patient whose MAP is sagging a little bit, going down from 17 to 65. At about this point, you push your phenylephrine, SVR goes up very nicely, and the MAP responds nicely. And here, the cardiac output is well maintained in that 5, 5.3, 5.4 range. Everything is good. Next slide. The other side is the same patient. Now, MAP was low. You pushed phenylephrine here. SVR goes up. MAP goes up. But cardiac output, look at the scale. The scale has changed. The cardiac output actually goes down from 6 to 5 to 4 to less than 4. This patient is on the wrong side of the Frank-Starling curve. If you don't know the cardiac output, you're actually doing harm to this patient by driving the MAP all the way up to 80 like you've tried to do here. Next slide. Afterload increase is not always the right answer. We've recently done some work at our institution where we've seen intraoperative phenylephrine, which is very commonly used in the United States all the time to keep the blood pressure high intraoperatively, is very strongly associated with postoperative AKI. Next slide. This is our unpublished work. So far as the duration of phenylephrine infusion in minutes increased, the odds of AKI started increasing as well. And about 4 hours of phenylephrine use, about 240 minutes, is when they reached a statistically significant point. This doesn't mean to say that you should allow hypotension. No, that's not what I mean to say here. What I mean to say here is unnecessary and continuous use of phenylephrine without knowing flow dynamics may be causing harm to your patients, especially patients who are otherwise under-resuscitated. So you could use other means to get your blood pressure up. Give them fluid, give them inotropes, lighten your plane of anesthesia. Use a more balanced approach to manage intraoperative hypotension. Next slide. And again, Monty Mythe and colleagues have repeated the same work on animal experiments where they've shown that, when animals bleed and they're given vasoconstrictors, it doesn't really help their microcirculation. Next slide. Finally, can we move from a reactive to a proactive approach with hypotension? All this while, we waited for hypotension to occur. We've been in this red area, hypotension occurs. We then respond to it. We're generally late in our treatment. We want to move to this proactive zone where we actually can prevent hypotension from happening. Next slide. So how do we prevent hypotension from happening? I think something that has really come up in a big way in the last few years is the use of artificial intelligence to actually look at all of these features in an arterial line waveform. And Firas Hatib's work, along with Maxine Kennison at UC Irvine, helped come up with something called the Hypotension Prediction Index. Next slide. What is the Hypotension Prediction Index? It is a probability of hypotension that is yet to occur. So as the HPI number here on the left-hand side column increases, so does the event rate and the time to event. The event here being a MAP less than 65. So very commonly used monitoring system here. And this is how the HPI secondary screen looks like on an Edwards monitor. And once you reach a MAP here, HPI of 86, then there's almost a 90% likelihood that within the next 5 minutes, your patient is going to have hypotension of some sort. Next slide. The this is an example, right? On the black line here is HPI. The red is a map. The map starts dropping here from 190 to 85 to about 80. HPI starts going up. The HPI has reached 85 at about this point. The map is still okay, but 7 minutes later, the map is less than 65. This is what the HPI has predicted. This is the lead time it's going to give you. This is where you can intervene to prevent this from happening. Because once it gets to 65, then it will overshoot and go to 55 as well. And you'll always be a few minutes late if you play catch up with hypotension. Next slide. And very quickly, there's been large randomized trials. This one from the Dutch group that was headed by senior author Denise Wielo. They had a remarkable trial in the Netherlands with HPI where they saw 75% reduction in intraoperative hypotension compared to the general standard of care group. Next slide. Colleagues at Cleveland Clinic did the same test in 216 patients and actually did not find a difference in HPI, whether it was actually leading to a difference in the amount of hypotension. The difference in the two studies being that the Dutch group was very, very compliant with using HPI and actually doing things that the monitor was telling them to do, whereas this group, the actual compliance with the HPI was very, very poor. Now, the message here being is that monitors by themselves don't solve problems. If you don't work with your monitors and actually intervene, then it doesn't really help. Next slide. Cardiac surgery, real quick. Very little data around blood pressure and hypotension, but this just published from the group in Harvard actually does show that as the MAP drops less than 65, there is a very strong association with the composite primary outcome of major cerebrovascular and cardiovascular events. So blood pressure in cardiac surgery is also important, and it is specifically important in the off bypass period when your patient comes off pump or not or hasn't gone on pump as yet. Next slide. We are working exquisitely in the cardiac surgical environment. We are doing something called the HPI care trial, where we are randomizing patients to either standard of care blood pressure management or HPI guided blood pressure management. Our protocol starts when the patients come off cardiopulmonary bypass and follows them for 8 hours in the CVICU. Next slide. This is the HPI care trial that I just talked to you about, just started enrollment, and hopefully we'll have some good answers for management of cardiac surgical hemodynamics for you. Next slide. And we're also part of the HPI Smart BP group. This is also a large trial, this time in non-cardiac surgery, 20 sites across the US, 1,500 patients. Importantly, using HPI in the non-cardiac surgical world, randomizing to HPI versus standard of care. Look at the outcome. The outcome is a composite of 30-day moderate to severe perfusion-related complications, which really means that if we're able to show a difference here, it will be a practice-changing publication and a practice-changing event, because this will really show that prevention of hypotension is associated with it not just associated, it does cause and improve survival one way or the other. Next slide. So this is about the end of my presentation. I've tried to answer a lot of different questions today. Blood pressure, numbers, detection of hypotension, monitoring of hypotension, a more personalized precision-based medicine approach to hypotension. Can we understand the balance between contractility, afterload, and volume replacement? How do we predict and prevent hypotension? How do we try to operationalize all of it? A lot of these questions have been answered. A lot of these questions are still being worked on in terms of the evidence. And I hope that I've provided you some education. Next slide. And this is my group of research fellows, research nurses, research technicians, and students. We call ourselves the Perioperative Outcomes and Informatics Collaborative. Next slide. We welcome international and global collaboration. So please go to our website. If anyone's interested, shoot me an email. My email's over here. The link to our website is right here at the bottom. I would love to hear from you. Thank you all for your patience. And with that, I come to the end of my presentation. Open for questions.
Awesome. That's great. Thank you so much, Dr. Khanna, for the really insightful and a very comprehensive presentation. Let me just turn my camera on. Right. So thanks so much, Dr. Khanna. I think your presentation was really very insightful. A lot of research, and you could really see the amount of research and extent of practice that you have had in this area of intraoperative hypotension, and overall, I would say it's more on the perioperative hypertension as well. So thank you so much for the excellent presentation. Some of the key points which I could really help highlight or summarize is you talked about, is there any safe period of hypertension, or is induced hypertension safe enough? So which is something I think really insightful. A lot of patients who we see with chronic hypertension, how to deal with them. So these are some of the common questions that we keep getting. Again, the use of whether absolute thresholds, or should we use a reduction from baseline of MAP. And again, is it only MAP, right? Because there is systolic, there is diastolic, there is pulse pressure. So you put in a lot of light on that as well. So I think we have some questions in the chat box. What we'll do is I will encourage all the attendees in the meeting here to put in your questions in the chat box here, and we can try to take them one by one. So Dr. Khanna, there's one question from, I'll just go through, from Dr. Gopalan. So the question is, does intraoperative hypertension be as deleterious as intraoperative hypotension? And is the incidence of AKI and MINS more with hypotensive patients?
So yeah, the question is hypertension as bad as hypotension? This work has actually been just published by Dan Sessler and colleagues, and they've actually looked at intraoperative hypertension as well. And interestingly, and very much expectedly, they did not see an association of intraoperative hypertension with myocardial injury and acute kidney injury. And if they did see a relationship, it wasn't as strong as hypotension. So hypotension seems to be the bad actor. Hypertension, yes, traditionally we know that, if a patient comes to the operating room with a uncontrolled blood pressure, really tachycardic, and then you're doing laryngoscopy, you're going to increase blood pressure even more and probably make them more tachycardic. So you should be really, really careful, because someone could have a head bleed or intraoperative intracranial hemorrhage, or especially someone who has an aneurysm sitting there. And clearly it's not great practice, but intraoperative hypotension appears to be the real bad actor in terms of perfusion-related problems, not hypertension.
All right, thanks, Dr. Khanna. Another question from Dr. Muthukumaran is, there is a debate on which target to chase, whether it should be pressure-based or whether it should be flow-based. And are there any studies which have shown that MAP less than 65 is always associated with the lower cardiac output? And what if BP is less than 65, but cardiac output or flow is still acceptable?
That's a great question. And I will tell you that in the perfect world, if I could monitor MAP and flow on every patient, then I personally would target therapy to adequacy of flow. I do believe that if your flow is adequate, then even you and me right now, probably both of us don't need a MAP of 65, right? Someone's sweet spot might be a MAP of 60, some months might be 55, and some months might be 70 or 75. The problem is just looking at MAP alone, we are limited. So we go with a higher MAP because we feel that higher MAPs will at least give us some sense of security. So my short answer would be, if you don't have the ability to monitor cardiac output or stroke volume or other flow parameters, then go with your MAP. At least keep your patient a MAP of 65 or more. If you have the ability to monitor cardiac output, which more and more of us do monitor cardiac output without the Swan GANs, then do monitor it, because it's really, really important, and it's going to provide you extra information that's going to allow you to titrate your MAP appropriately.
All right, thanks, Dr. Khanna. On the question and a comment from Dr. Men, Thank you for your presentation, Dr. Khanna. Do you think we need to have prevention treatment with vasopressors of perioperative hypertension? So I believe you tried to answer this a little bit, when you talked about phenylephrine and some of the trials.
Yeah, if men, I understand your question. You are trying to ask me whether we should try and almost prophylactically give vasopressors. Well, I'll say that, I think it's really important to prevent hypotension, but vasopressors are not the only solution to prevent hypotension. Inotropes are probably as important, and fluid loading is also as important. So make your approach a more balanced approach to prevention of hypotension. Don't just rely on just that one afterload increasing agent.
Then there's a question. So just to let you know, Dr. Khanna, there's a group of probably about 100 clinicians in different hospitals within India. And I think this is a question from one of the hospitals from Dr. Pushpalata. The question is there any study on intermediate IOH and its deleterious effects? So I believe it's intermittent IOH and not in a continuous fashion, probably.
Yeah, so if it really means intermittent intraoperative hypotension, well, I would say, if you look at the data does suggest that even a few minutes of intraoperative hypotension is associated with harm. Now, I will say that the way I look at it is that, you should always look at the denominator, the duration of surgery. So obviously for 6-hour procedure, maybe, half an hour hypotension in a 6-hour procedure spread over 5 minutes every hour is probably still tolerable, but for a 2-hour procedure, a half an hour period of hypotension is probably really, really bad. So you have to look at that denominator as well when you look at the amount of hypotension. I think all hypotension is bad, whether it's intermittent or it's continuous.
It looks like a continuation question is, is there any study on immediate post-op hypotension also and its deleterious effects?
So lots and lots of studies. I didn't have the time to go over everything today, but lots and lots of work. In fact, to be very honest with you, we do know that post-operative hypotension is more strongly associated with myocardial injury than intraoperative hypertension. In fact, increases the risk by a factor of 3 or 4. So the same duration of 10 minutes of intraoperative hypotension versus 10 minutes of hypotension in the PACU or the general care floor, 3 to 4 times increased risk of myocardial injury with post-operative hypotension. The biggest problem, and it's a problem not just in India, but all over the world, is that we don't monitor our patients post-operatively as aggressively as we monitor them intraoperatively. So we miss a lot of post-operative hypotension, plus the fact that myocardial injury is totally asymptomatic. Patients don't have chest pain like myocardial infarction. So it's really, really dangerous with post-operative hypotension.
Right. Thanks, Dr. Khanna. If anyone of the attendees has any more questions, please feel free to type in. Okay, there's one more question coming from Dr. Swami. Is role of intraoperative induced hypotension in current scenario and the knowledge? I don't know if it's a question or a comment as such.
Well, I showed you the book chapter, and actually I want to compliment someone here. I was looking at the comment. Someone has identified that book as well, Devesh Arora, Wiley's textbook of anesthesia. He got that right. I didn't say it, but congratulations. You knew where that chapter was coming from. So as of today, in modern day practice, I think there is induced hypotension has very little scope, if anything at all. It is so dangerous to expose your patients to those low blood pressures. And, the risk-benefit situation, we know that the benefits are very minimal and the risks are too much. And really, I don't think there is any justification of practice of induced hypotension in modern day anesthesia.
True. Thanks, Dr. Khanna. So yeah, I think we're just at time here, and I know it's 11:30 p.m. for you. Okay, I think there is one more question, which is the target for TWA map. Is it less than 65? So I believe it's more on the surface area of the whole hypertension episodes, and you divide it by the duration of surgery. So that's probably what it talks about. So with that, I think it's pretty great. Thank you so much, Dr. Khanna, for all the insights and really a great sharing of all the research that's ongoing, plus all the upcoming trials. It's really great. Okay, let me see. There is some question coming in still. Okay. That's good. That's good. It looks like people are just trying to give their comments about this topic, and there is a lot of interest, and we see a lot of proactive hypertension management. So really great to see you talk about going from reactive to a proactive way of treating hypertension, and probably preventing more of complications like AKI and MINS in the patients. So thank you so much, Dr. Khanna. Any just before we close, any key suggestions or advice or any words from your end to all the listeners over here?
Well, first of all, thank you. Great discussion. Thank you for your patience. I know this is very heavy and dense data, lots of numbers, lots of associations. The most important thing I want you all to remember is that monitor your patients aggressively. Take hemodynamics really, really seriously. It doesn't have to be a map number that you have to remember, but set yourself a threshold. Say, I want my patient to be at a map of 60 or 70 or whatever you want your patient to be at, and then really defend that map and defend it well. Don't just put every patient on phenylephrine and walk away. Understand your patient's cardiovascular physiology and then manage the map. And yes, all hypotension is bad, and we have to be more aggressive about management of hemodynamics. Plus, again, I haven't said enough about documentation and maintaining your data and then using it to improve your outcomes afterwards. I think that is also extremely, extremely important.
Very true. Thank you so much. Thanks a lot again. On behalf of Edwards Life Sciences, thank you so much, Dr. Khanna, for the brilliant presentation. And again, for all the attendees, here with, thank you so much for being, with us throughout the whole meeting and, being engaging with all the good questions. We would like to get your feedbacks, for this whole meeting as well. So I'll just quickly go ahead and share a QR code from my end, which you all can scan with your phones. And please feel free to, give any valuable feedback so we can keep continuing, great programs like this. So with that, I would formally like to thank all of you. And especially Dr. Khanna, thank you so much. Have a good night and take care. Thank you.